Rupture of sinus of Valsalva, known in short as RSOV, is a rare but clinically significant clinical event, usually involving a deficiency in the aortic media. It typically presents as a thin-walled windsock-like aneurysm that eventually ruptures into an adjacent chamber, creating a significant left-to-right shunt. Sinus of Valsalva consists of three anatomical dilatations of the aortic root: the right, left, and non-coronary sinuses. Most RSOVs are congenital, caused by a lack of continuity between the aortic media and the annulus fibrosus of the aortic wall. Right coronary sinus is involved in about 70 to 80% cases, and it usually ruptures into right ventricle. Non-coronary sinus is less common and usually ruptures into the right atrium. Left coronary sinus is rare, and rupture, if it occurs, can induce. Sinus of Valsalva consists of three anatomical dilatations of the aortic root: the right, left, and non-coronary sinuses. Most RSOVs are congenital, caused by a lack of continuity between the aortic media and the annulus fibrosus of the aortic wall. Right coronary sinus is involved in about 70 to 80% cases, and it usually ruptures into right ventricle. Non-coronary sinus is less common and usually ruptures into the right atrium. Rupture from the left coronary sinus is rare, and if it occurs, it could be into left atrium or pericardium. RSOV is often associated with other abnormalities like ventricular septal defect, which is usually supracrystal or subpulmonic. Bicuspid aortic valve may be present in small number of cases, and aortic regurgitation may develop due to lack of support for the aortic leaflets or the Venturi effect of the shunt pulling the leaflet down. Transthoracic and transesophageal echocardiography are the gold standards for diagnosis. Color Doppler reveals the continuous high-velocity jet. Windsock appearance in the right ventricular outflow tract is characteristic. It can occur in unruptured aneurysm as well. Cardiac MRI and CT are excellent for defining the anatomy and measuring the size of the aneurysm if echo windows are suboptimal. Cardiac catheterization is primarily used to quantify the shunt, that is the QP by QS ratio, and assess the coronary arteries before surgical repair. Since RSOV, PDA, and coronary artery fistula all produce continuous murmurs, the spot the difference lies primarily in the location of maximal intensity and the timing of the peak. Maximal intensity is at lowest left sternal border or xiphoid area for rupture of sinus of Valsalva. In case of PDA, it is left infraclavicular area, that is the Gibson's area. In coronary artery fistula, the location of maximal intensity is variable, often over lower sternum or right side, depends on the site of drainage. RSOV murmur peaks in late systole or early diastole when the pressure gradient is highest. When RSOV is into the right ventricle, there is a typical diastolic accentuation because the windsock tract gets obliterated in systole due to right ventricular contraction. In PDA, the murmur peaks around the second heart sound. In coronary artery fistula, often there is a crescendo-decrescendo quality in both phases. Classic description is washing machine or machinery murmur, which is very superficial sounding in RSOV. PDA, it is again classical machinery murmur, sometimes also called train in tunnel murmur, Gibson's murmur. In coronary artery fistula, it is to and fro or continuous, may be softer than RSOV, or rather it is very softer than RSOV in most cases. RSOV murmur is very loud. Wide pulse pressure is seen in both RSOV and RSOV into right-sided chambers, and in PDA because in PDA there is a rapid runoff into the pulmonary artery, while in case of RSOV there is rapid runoff into RV or RA. While in coronary artery fistula there is hardly any change in the pulse pressure. It's usually normal or slightly wide maybe. As mentioned, while all three are continuous murmurs, the RSOV murmur sounds closer to the ear because the rupture often occurs into the right-sided chambers, which are right under the chest wall. Unlike a venous hum, which is another continuous murmur differential, these murmurs do not disappear when the patient lies flat or turns their head to one side. If you see a patient with a non-VSD who suddenly develops a loud new continuous murmur and heart failure, RSOV is the diagnosis until proven otherwise. We know that there is an association between VSD and RSOV, especially for supracrystal or subpulmonic VSD. Once ruptured, the prognosis is poor without intervention, typically leading to death from heart failure within a year. Surgical repair is the traditional treatment involving excision of the windsock and patch closure, usually via a double approach through both the aorta and the receiving chamber. In selected cases where the anatomy is favorable, like good margins from the coronary ostia and the aortic wall, Amplatzer duct occluders or similar devices are increasingly being used.